And welcome everyone to the first of our HCM education series, Diagnosis, Therapeutics, and Enhanced Pathways. And it's designed to educate about an important condition that is extremely common. And tonight is really just an overview. It's an idea. The idea tonight is to get you interested in what topics are going to come. And at the end, I'm going to show you that full list of topics for all that is going to be discussed about HCM, where we are, where we're headed, and tonight we're going to talk about some unmet needs. So join me as we talk about HCM, the pathophysiology, the definition, epidemiology, its presentation, and the importance of building an HCM program. These are my disclosures that are relevant for this discussion. So HCM is a heterogeneous disease, and it requires a heterogeneous approach. Its genotype, phenotype, and hemodynamics are different from patient to patient, and that dictates the presenting symptoms, the natural history of the individual, and then the therapy reflects what all of those go into the symptoms that bring the patient to your attention. Now, you may know this condition as one of the 70 plus names we have referred to this condition of hypertrophic cardiomyopathy. And these days we just simply refer to it as HCM, and it's either obstructive HCM or non-obstructive HCM. We'll talk about that. This is an extremely prevalent condition. 125 countries have described some version of HCM. That's over 90% of the world, and worldwide, the prevalence, depending on which study you reference, is somewhere between 1 in 200 and 1 in 500 worldwide. So that's up to 20 million people worldwide have some version of hypertrophic cardiomyopathy. So if you assume 1 in 500 for the United States, that's an estimated patient number of about 700,000. We know currently about 100,000 are diagnosed with HCM, which means about 85 to 90% of those with HCM go undiagnosed or misdiagnosed. So this is an important concept because it means we're not doing a great job of identifying it, which is what this entire series is about. How do we improve the diagnosis of a condition that we have treatment options for? So the definition is fairly simple. Hypertrophied, non-dilated LV in the absence of another cause, either systemic, metabolic, or a multi-organ syndrome that is associated with left ventricular hypertrophy. So it's hypertrophy in any pattern with or without obstruction. That's how we define HCM. So this is a normal heart in the upper corner here. You can see you can have hypertrophy at the basal septum, adjust the septum, the so-called reverse curve or the classical HCM. You can have apical HCM with or without aneurysm. This shows absence of an aneurysm. This is the neutral subtype, and then the rarest neutral lateral wall subtype of HCM. So hypertrophy with or without obstruction in any of these patterns in the absence of another cause is how we define hypertrophic cardiomyopathy. So it really requires a comprehensive approach. We talked about their family history, who they are, what their personal history is, specifically a history of hypertension. I want to know about a family history of sudden death, unexplained death, car crashes that can't be explained, athletes in their family that died suddenly, even if they were older athletes that were unexplained deaths in their family are important to try and tease out. A comprehensive physical exam, listening for obstruction, looking for hypertrophy at the PMI, and of course, using the electrocardiogram. We're going to dive into all that. but the signs and symptoms are going to drive your discussion. So although many are asymptomatic, others clearly present with symptoms that we have to recognize: breathlessness, chest pain, palpitations, passing out, whether it's due to LVOT obstruction or one of these two common arrhythmias in HCM, either VT or atrial fibrillation, are reasons for you to start to think about whether or not this is HCM. Of course, if you see somebody with sudden cardiac arrest, that's going to, of course, prompt you to think about HCM as a known cause of of sudden cardiac arrest. So the challenge is that these symptoms overlap with typical symptoms seen in a cardiology practice, right? Coronary artery disease, valvular heart disease, and other types of cardiomyopathies can look and present in a similar way. So some people refer to this as the great masquerader or hiding in plain sight. So because it's so common, however, you should really be thinking of this early on. So if you have a common disease that presents with common symptoms, hypertrophic cardiomyopathy should be high on the list. And even if you see LV systolic dysfunction, look at the muscle itself, look at the ECG, and look at potentially old echoes and see if this is end stage hypertrophic cardiomyopathy, or often referred to as the burned out version of HCM. And remember to exclude other causes like infiltrative cardiomyopathies, such as amyloid heart disease. Look for clinical features of Fabry, uncontrolled hypertension, multiple drugs, many years leading to hypertrophy can look like HCM. But remember, wall thickness of 20 millimeters caused by hypertension would be exceedingly uncommon. Less than 5% of uncontrolled hypertension will lead to that degree of hypertrophy. And because hypertension is so common, you can absolutely have both. Look for a family history of cardiomyopathy. And again, back to amyloid, a common overlapping misdiagnosis. Look for neurologic findings, carpal tunnel syndrome, systemic symptoms that may point you towards one of the mimics of hypertrophic cardiomyopathy. And then, of course, the age at presentation and additional testing can help guide you. We'll talk about more of the imaging, but if they're a younger individual, that's going to lead you more towards Danon or PRKAG2 or other types of mimics that look like this, that look like hypertrophy. If they're older, then amyloid and hypertensive heart disease. If they have multi-systemic involvement, think about other causes like Fabry disease. Blood tests, the ECG, and a cardiac MRI will all contribute to that, to deciding which type of hypertrophy this is. And I'll show you some examples of that towards the end. And remember, although it may seem simple, and we've gone over this for years, it's often missed. This is data from Lisa Sahlberg at the HCMA in 2016, showing us the number of individuals with a misdiagnosis, often being called asthma or exercise-induced or athletically induced asthma, panic attacks, anxiety, depression, mitral valve prolapse are all misdiagnosis of hypertrophic cardiomyopathy, and patients can often go up to 5 years or more without a diagnosis, despite having some classic features of HCM, because they're misdiagnosed as often as some of the diseases in front of you. So HCM patients often present with one of the four options. So you should suspect it if you have an abnormal physical exam: a provocable heart murmur that gets worse with squat to stand murmur, squat to stand maneuver, or increases with Valsalva. If they have an abnormal PMI that's sustained, or BiFib, that would lead you more towards a diagnosis of hypertrophic cardiomyopathy, or at least a thick ventricle. Often patients present with an abnormal echocardiogram or an abnormal ECG. I'm going to show you what those examples look like. And then on occasion, they make it easy, right? They come in with a family history of hypertrophic cardiomyopathy, and they tell you, I'm here to be evaluated. My uncle, my mom, my brother was just diagnosed with hypertrophic cardiomyopathy. But it often starts with the electrocardiogram. And ideally, tonight, we can take away this take-home message that the ECG is a powerful tool for evaluating those who come to you with the symptoms we talked about before. So here's a typical ECG of hypertrophic cardiomyopathy, showing deep T-wave inversions, in this case, diffusely associated with ST depression here and T wave inversions in the inferior, the lateral, and the high lateral wall. And here we have biatrial enlargement. Left atrium is enlarged, as is the right atrium. This is an overtly abnormal ECG, and hopefully for all of us would prompt a cardiac imaging study to investigate further. But there are typical ECG features that Dr. Lakdawala in 2011 alerted us to for a diagnosis of HCM. Now, remember, about 10% of the time, the ECG is going to be normal in hypertrophic cardiomyopathy, but it's the other 90% that we should really always get correct. Left ventricular hypertrophy is not as helpful in controls versus pre-HCM and HCM, although when you see LVH criteria, of course, you're going to start to think about this, but specifically when you see Q waves or ST depression or diffuse T wave inversions, you can see a marked difference between the group in hypertrophic cardiomyopathy compared with controls. And it's a helpful tool to discern and make you think about whether or not this is hypertrophic cardiomyopathy. So here's some real life, some clinical examples of clear diffuse T wave inversions here out through V6. This is a mandatory imaging study and requires ongoing surveillance to look for blooming of hypertrophic cardiomyopathy or right ventricular cardiomyopathy in some cases. But even if it's normal once, it requires ongoing surveillance. Here's an example of left bundle branch block, always pathologic and requires, again, imaging to evaluate and then usually long-term surveillance. Here's an example of some Q waves. Here's high lateral wall 1 and AVL, as well as out through V5 and V6. Very specific for hypertrophic cardiomyopathy. When you identify T wave inversions beyond V4, high lateral leads as well, left bundle branch block or Q waves, HCM should bubble to the top of your questions and your clinical observations. And then it can help you if you find a thicker heart, a low voltage ECG like I'm showing you here may make you think about amyloid heart disease. So the ECG not only rules in hypertrophic cardiomyopathy, it can also point you towards other mimics of HCM. So this is a reference directly from the guidelines published in 2022 for an evaluation of HCM, and they call out the ECG as an important tool. Hypertrophy, deep T wave inversions, low voltage, or some pre-excitation and short PR intervals should make you think about hypertrophic cardiomyopathy as a diagnosis. So the history, the physical, the ECG, critical pieces to this puzzle, but cardiac imaging is still the most important tool we utilize to investigate hypertrophic cardiomyopathy, whether it's echo or cardiac MRI. These are the main tools we use to make a diagnosis when suspected by the other findings. And we always say everybody gets an echo. And it should be a comprehensive 2D echocardiogram with Doppler and tissue Doppler, but it's hypertrophy that rules the roost. So you need 15 millimeters or thicker to make a diagnosis of hypertrophic cardiomyopathy. As we said, it's typically a non-dilated left ventricle, often less than 45 millimeters, should make you think about a pathologic ventricle rather than some physiologic adaptations, which we sometimes see in elite level athletes, specifically static or strength level athletes. And it's a comprehensive echo, as we mentioned. You're going to do the whole story, 2D, contrast, M mode, color Doppler, PW and CW Doppler to identify the pattern and the severity of hypertrophy, not only for diagnosis, but also for prognosis and risk stratification. You're going to assess for diastolic function. Dysfunction is the hallmark of HCM. When absent, it should point you towards an alternative cause such as athletic heart. Look for visual features of HCM and understand the mechanism of outflow tract obstruction. So looking for the mitral valve, systolic anterior motion, septal contact, locate the obstruction, of course, quantitate the severity, and that can help you assist in treatment of the HCM patient. All of these can. So the degree of hypertrophy, non-obstructive versus obstructive HCM, and eliciting obstruction to identify if someone has symptoms are all the treatment options that can come after the diagnosis simply using an echocardiogram. So there are many, quote, faces of hypertrophic cardiomyopathy. These are different versions of the condition I showed you earlier in the schematic, and you can see Hypertrophy in the upper left corner. This is non-obstructive apical here in the middle. Below that is midventricular or mid-cavitary obstruction with a clear apical aneurysm here. Massive hypertrophy on the end, with marked hypertrophy here in the septum, as well as on this lower right-hand section with obstruction. And then here you can see that classic reverse basal septal hypertrophy, long anterior leaflet, systolic anterior motion, septal contact, and a posteriorly directed mitral regurgitation jet. Classic features of hypertrophic cardiomyopathy. So all of these can be HCM in the absence of another cause. This is HCM until proven otherwise. You can also do some strain imaging to help you differentiate between patterns of hypertrophy and diagnoses. Apical HCM and asymmetric septal hypertrophy variant here with reduction in the areas that are hypertrophied. This is often the apical HCM where everything else is normal except for the tip of the heart, the septal here showing marked reductions and where the hypertrophy is the thickest. And then LVH due to aortic stenosis has a variable pattern seen here. And then the quote cherry on top here on the end with apical sparing consistent with cardiac amyloidosis. But as we talked about earlier, this disease then further separates into the obstructive and the non-obstructive. And this is a disease of obstruction. About 2/3 or 70% will have some obstruction, either a third at rest, another third with provocation, either a stress echo or a squat to stand maneuver or something to bring out the obstruction. A Valsalva maneuver, often the most often elicited response. And then that remaining third is the non-obstructive. And this is important because the symptoms correlate to obstruction in many cases, but the treatments are reliant on distinguishing between provocative obstruction, resting obstruction, and of course, non-obstructive HCM. And the therapies can be different between the non-obstructive and the resting and the obstructive group. So the symptoms come from the obstruction. Systolic anterior motion and septal contact shown here with this long anterior leaflet. Well, they lead to chest pain, pressure, breathlessness, and fatigue. And this is the target to treat the symptoms related to the obstruction from hypertrophic cardiomyopathy. This is easily done by a routine echo. Here's an echo across the top, a parasternal long axis showing SAM and septal contact with the arrow sign there showing clear outflow tract obstruction and a posteriorly directed mitral regurgitation jet. Important features confirming the obstruction is related to SAM and not some fixed obstruction, and that the mitral regurgitation is related to the systolic anterior motion. Obstructive HCM, we define that as a gradient over 30. Most folks do not have symptoms until the gradient gets above 50. So if you see no obstruction at rest, you want to do some provocation to bring it above 30 and ideally 50. But if folks have symptoms and their gradient is 30, 35, you want to do some other provocative maneuvers to convince yourself that it's truly obstructive HCM causing the symptoms and not non-obstructive, as the therapies will change based on that. And then the echo can also help you look for other features. So it's not just the hypertrophy that causes obstruction, but it's papillary muscle displacement and rearrangement. There's a common phenomenon where multiple papillary muscles are identified, a double bifid posteromedial gradient. That elongated anterior leaflet leads to systolic anterior motion. And this can be identified by echocardiogram. Here are some contrast and non-contrast showing at multiple papillary muscles shown here, contrast with apically displaced papillary muscles in some off-axis views confirming the direction of those papillary muscle insertions. And then you can see this direct insertion onto the mitral valve, anterior mitral valve, and it's actually the papillary muscle that is causing the obstruction. A critical piece to the puzzle, as the therapies, the opportunities to treat the individual will differ based on the mechanism of obstruction as well as its presence or not. So echo is clearly important, but MRI increasingly has played an important role in not only helping us understand hypertrophic cardiomyopathy, but also better treating HCM. So much like we saw in echo, HCM actually has an important tool for identifying hypertrophy. It helps with the pattern and the magnitude of hypertrophy, as this is a heterogeneous disease, as we showed you with echo. But the contrast resolution of MRI helps this even more so compared to echo. It's an important tool to confirm a diagnosis and to help with a diagnosis in those that are unclear, because MRI actually sees segments that the echo has trouble with. Specifically, there are regions of hypertrophy better seen by MRI and poorly seen by echo, such as the apex, the posterior interventricular septum, and the basal anterior free wall, as well as some non-contiguous areas of hypertrophy where you have thickness next to normal thickness. It's easier to identify those separations using MRI compared to echo. So multimodality imaging is really the norm for hypertrophic cardiomyopathy. It's an important way we evaluate HCM, and it's not echo or MRI, it's echo and MRI to establish the diagnosis, the phenotype, and also to evaluate a differential diagnosis, as we showed you already. And then it helps you evaluate the symptoms. Are they obstructive or are they non-obstructive? And the echo and the MRI will both do that, looking for hypertrophy, evaluating the mitral valve leaflets, the size, systolic anterior motion with septal contact, evaluating papillary muscle distribution, and then looking at the apex and for mid-cavitary obstruction, as these are treated in a different way. And then finally, it helps you assess risk of sudden death and coronary artery disease, and detection are all part of the evaluation of an individual with HCM, as these can also cause symptoms in those with hypertrophic cardiomyopathy. Now, MRI shows scar in a unique way, which is a common feature of HCM. About 2/3 of those with HCM will have some version of scar, and it can be in any of the patterns you see that you see here. But the more scar you have, the higher the risk. Here's a meta-analysis of almost 3,000 HCM patients looking at the extent of late gadolinium enhancement, or SCAR, as a strong prognostic marker in HCM to predict sudden cardiac death events, progression towards heart failure, and to look for apical scar, and even this apical aneurysm shown here by that red arrow, are all better identified by cardiac MRI compared to echo. So the meta-analysis went on further to say the extent of LGE was important to identify all-cause mortality, risks for cardiovascular mortality, specifically heart failure death, sudden cardiac death events. So it's the extent of LGE as a strong, maybe the strongest prognostic marker in HCM to evaluate those at risk for sudden cardiac arrest, and of course, long-term complications related to that. But much like we saw with echo and strain imaging and the pattern, it can also help with a differential diagnosis. So MRI, specifically late gadolinium enhancement, can help you evaluate Fabry and amyloid heart disease, and then it can help you better identify if it's truly a thick heart or not, as its resolution for identifying hypertrophy is improved with MRI compared with echo. So diagnostic tool for both HCM as well as a differential diagnosis, and then it helps with prognosis with regards to late gadolinium enhancement. So we know this is a genetic disease. We consider it an autosomal dominant condition, HCM in total. It has variable phenotypic expression, so just carrying the gene doesn't mean you're going to get the disease. Absence of the gene doesn't mean that you don't have hypertrophic cardiomyopathy. It simply means our technology is not good enough to identify the gene responsible for your hypertrophy. And absence of the gene doesn't, presence of the gene doesn't require you to, is not required for a diagnosis. So it's a clinical diagnosis based on echocardiography, usually the ECG integrated with a history, and the genetic testing helps you for downstream family screening as you look for the typical genes associated with that. MYH7, MYBPC3, and troponin genes are the more common genetic mutations identified related to HCM. And then you can use your imaging to help decide who might be best served with genetic testing. So the morphology is important to determine the positivity of the gene. So here are all the examples we talked about in terms of distribution: sigmoid, reverse curve, neutral, and apical. And you can see across the bottom, the pattern, the morphology determines who might be more likely to have a positive gene. So if you have a sigmoid septum, you're more likely to have obstruction, but you're much less likely to be gene positive. And if you have reverse curve shown here, about 80% of the time the genes are going to be positive, higher risk for fibrosis, but less likely to have obstruction. So all of the morphology you get from echo and from MRI are all important for all the things we talked about earlier, but can also guide your discussion with regards to genetic therapies. So this is a common utility where we identify, shown here, an MYBPC3 gene, and we use that for downstream evaluation of first degree relatives in those who want to use genes to identify if they carry the risk for development of hypertrophy related to HCM. But on occasion, it can actually help you with mimics as well. Here's two examples, one with GLA or Fabry disease here on the bottom, and then above that is TTR amyloid, both mimics of hypertrophic cardiomyopathy that the genetic test alerted us to beyond what you get from imaging. So we don't utilize it to make a diagnosis, but on occasion, it helps us make a diagnosis of an alternative mimic that we thought that we were not thinking of or didn't really suspect based on the other imaging techniques. So once you make the diagnosis, then you're going to enter one of the pathways we refer to for hypertrophic cardiomyopathy. Many, this is have a low risk. They are gene positive or not, and they're without symptoms, and they carry on with follow-up in your program throughout their entire life. This is a disease of longevity. Most patients live well into their 80s when managed appropriately. HCM is a disease that has a normal life expectancy. And others need to be sorted out so that they can help lead that normal lifespan, and they're going to fall into either those at risk for sudden cardiac death, heart failure from either obstruction or non-obstruction, or then atrial fibrillation and the risk of stroke, as atrial fib is the most common arrhythmia associated with HCM. And then we can integrate therapies for each of those. So this is a contemporary treatable condition. So the diagnosis is critical so we can employ the therapies to help improve outcomes in those with hypertrophic cardiomyopathy. So let's start with obstruction. We said this is a disease of obstruction, and in those with refractory treatment to beta blocker and calcium channel blocker, obstruction is predominantly treated by either surgery or alcohol ablation to relieve that obstruction, the so-called septal reduction therapies. But modern therapy now with cardiac myosin inhibitors has shown us that we can use medical therapy beyond beta blocker and calcium channel blockers, really now with some robust data showing marked improvement, often surgical level reduction in gradients with cardiac myosin inhibitors. And it keys on the fact that HCM is a hypercontractile disease compared with normal non-HCM hearts, and has enhanced interaction between actin and myosin bridges compared with normal non-HCM individuals. So what cardiac myosin inhibitors do is that they bind to those actin myosin bridges and tell them and put them into the relaxed phase, moving them more towards a normal heart. So I often explain this to patients as being similar to what we get with a rowing boat. HCM has too many rowers. And in converting that, myosin inhibitors tell some of those rowers, don't row. And it converts the too many rowers into a normal level of rowers and those with non-HCM, and improves their gradient, reduces their ejection fraction, and more importantly, improves their symptoms. So there's more work to be done in this space. New medical therapies are emerging, and they're going to unlock some understanding of HCM, which therapy for each patient. It's not a one size fits all, and we need to improve access to centers who are offering SRT options, all of those options, because we know that in centers of excellence, outcomes are better. Here's data recently published from the Cleveland Clinic and Jack in 2023, showing that whether we're talking about septal myectomy or alcohol septal ablation, there is an improvement based on volume. So larger centers of excellence have better outcomes than those who do not. So offering SRT options through larger centers is important, but access to them can be limited. This is again data from the HCMA. It's a little outdated from July of 2020, but it shows you that only a handful of centers are covering more than 1,500 patients on an annual basis, and that other center of excellence are still coming up to speed with regards to volume metrics in order to meet those high quality standards. And then you can still see on this map of the United States, there's a lot of white. Many centers, many states don't have any opportunities to care for those with hypertrophic cardiomyopathy. So there's a real opportunity to try and improve the ability to make those diagnoses in those states. Sudden cardiac death, maybe the most feared complication of HCM, has been investigated over the last 30 years. We now have a reasonable handle on risk factors for sudden cardiac arrest in HCM, and we know that ICDs are an important therapeutic intervention to reduce the risk of sudden cardiac arrest. But there's still more work to be done. There are still many who are having cardiac arrest despite no risk factors. So improvement in our risk stratification, perhaps there are novel markers we've yet to discover. And then what's the impact of some of these novel medications for reductions in sudden cardiac arrest? To date, we don't know the answer to that. Non-obstructive HCM continues to evolve in terms of therapeutic options. There are not a lot of options in this group. Only about 10% of patients with HCM with non-obstructive HCM progress on to the class 3, class 4 symptoms, but they have a higher risk of mortality and a need for heart transplant when they do, and access to that group is important. And we know that those therapies are also limited without a lot of long-term benefit. So advanced heart failure development prediction models are critical. Who's at risk? Can we prevent them from continuing to progress? And what about newer therapies for non-obstructive HCM? And what's the evolution of advanced interventions? Whether it's heart transplant or improvement in VADs, there are opportunities for improving outcomes in those with non-obstructive HCM. Atrial fibrillation and the risk of stroke is not trivial. This is actually the most common arrhythmia in HCM, accounting somewhere between 25 and up to 50% if you include asymptomatic diagnosis of atrial fib on devices like pacemakers and ICDs. Very, very common, and a high risk of stroke beyond what you get from CHADS VAS score. So there's opportunities with regards to identification and prediction models of who might develop atrial fib, improvements in portable detection. How can we improve those who have not yet developed AFib but may be at risk for it and could benefit from interventions for stroke reductions with medications or devices and newer therapies to improve rhythm control. In our practice, treating atrial fibrillation is extremely difficult and often requires multiple medicines and multiple interventions before you can get a handle on it. And it still often requires a shift in therapy long term. There's definitely more work to be done in the atrial fib space with regards to HCM. So this is why we think it really ought to be done as part of a program. This is how we do it here in Morristown, where we integrate our advanced imaging program with our arrhythmia team and our interventions with either the catheterization or surgical interventions to try and remove that extra muscle and improve symptoms related to obstructive hypertrophic cardiomyopathy. And it really requires a team. We're a standalone practice for hypertrophic cardiomyopathy, integrating our APPs, the center in total, our nurses, experts in the field with dedication to just seeing hypertrophic cardiomyopathy patients. Our sonographers help coordinate care with all of our nursing team and physicians. And of course, we try and engage them in research and database enrollment for longitudinal surveillance of this group. But it goes beyond that, and it really takes a comprehensive approach and a program to deliver, whether it's the electrophysiologists, the surgeons, the interventionists, the genetic counselors, or all of the other things that go into caring for those with HCM. We know that obesity is a risk factor for poor outcomes. The bariatric group is involved. We know that lung disease and mental illness go hand in hand with hypertrophic cardiomyopathy, and it's important to integrate all of that into the individual care of those with hypertrophic cardiomyopathy. So here's a scheme from the guideline, a schematic from the guidelines looking at elements of different levels of center. And you certainly don't have to be all the way in a comprehensive hypertrophic cardiomyopathy disease, comprehensive center of excellence. It could be a primary HCM center where you're referring in for some of the more complicated things like pregnancy and HCM where you may not have the experience, or potentially you're a referring primary cardiologist who says, I want to take care of my patients, but I need help managing them. And we do a lot of consultative work. We send them back for imaging after their therapies have been initiated, and we integrate our primary cardiologist into the HCM centers of excellence to do this as a group, because it's somewhat of a comprehensive and complicated initial algorithm for evaluating patients with HCM. So in those with suspected HCM, we reviewed all this, whether it's genetic testing or imaging or that comprehensive history. We have an hour for new patients and 30 minutes for follow-up patients, because it requires a lot of upfront work to make sure that we're caring for the entire HCM individual. So the histopathology, the fibrosis all match with the clinical features and the symptoms. So it's a nice mechanism for evaluation of athletes, for evaluation of those with hypertrophic cardiomyopathy. And as we said, this is common. We're all seeing this. And since this is a contemporary treatable condition with increasing options available really year over year, there is an urgent need to improve the diagnosis of HCM so we can better deliver those therapies to those with a diagnosis of HCM. So really all patients should be considered individual. And this is a treatable disease, but it's highly variable in expression and management, and its clinical course can vary quite a bit. There really is no typical HCM patient. And with an increased focus on HCM, it's leading to more medical therapies and evolution of recommendations with regards to exercise and their therapeutic options. So integrating a center of excellence for your group may have real value in serving your patients. So thank you for joining me as this introductory session, but you can see there are 9 more. We're going to talk about an improvement in diagnosis using AI, dive into each of the things we talked about tonight: diagnostic approaches, treatments, risk stratifications, a strategic plan, follow-up care, and recommendations with regards to improvement in overall quality, program evaluation, and even how to recommend exercise in those individuals. So I hope that you're going to join us over the next 6 to 12 months to learn more about HCM in this educational series from Viz AI, and I appreciate your attention tonight.
Do you think that all patients with HCM should be sent to the specialized HCM team?
I think it's there should be a collaboration. So we talk about a wheel and spoke model, right, where many patients will come in for a single evaluation, right? We evaluate them. We make sure that we talk about all the pieces that go into HCM, and then they often go back to their primary cardiologist, and they only come back if symptoms change. It really depends on the cardiologist and what their comfort level is. But it allows us to talk about new opportunities, make sure that they're being risk stratified. Do we offer genetic testing so that we can downstream evaluate individuals? So I do think at least a one-time visit is appropriate to go to a specialized HCM center. We know that folks who go to a specialized HCM center have better outcomes than those who do not. So just like we're doing with valve disease and amyloid or even specific cancers and other types of medicine, at least a visit to a specialty center to make sure that you're offering all that you can to those individuals, I think is important.
Right, thanks. And then on that, is your HCM center part of a larger heart failure clinic, or is it completely separate?
Great question. So we are a separate entity, although many places are integrated with a heart failure clinic. But make no mistake about it, we work hand in hand with our heart failure program. We refer to it here as actually heart success. So our heart success colleagues, we refer back and forth. So it's not unusual for a non-obstructive HCM individual for me to make the diagnosis, evaluate them, start the initial therapy, and then transfer home the heart failure. We make a diagnosis of amyloid or Fabry once a month. So it's often that I'm evaluating somebody for HCM and I'm saying, no, you've got amyloid cardiomyopathy or you've got Fabry. Off you go to the medical geneticist and off you go to the heart failure program, and then they take over in that regard. But it's definitely back and forth, and the HCM program also benefits from the heart failure program. So, number one, they make a diagnosis often of non-obstructive HCM. They send them over to us, and we start that initial therapy. And then between the two of us, we improve. We think the outcomes of that group. This year, we've transplanted from this center 3 HCM hearts just in the last 6 months. So it's absolutely an integration between the two groups. It is not that we are standalone and siloed, but we do have a separate entity that works in collaboration with our heart failure program. It's really an important statement.
So a few others that came through the chat, but given your expertise in sports cardiology, are there recommended cardiac screenings for athletes? And if so, when would they be recommended?
So we know that this is a controversial topic, right? So whether or not we should integrate ECGs or not. And what I'll say is that history and physical exam is still very powerful. ECGs are often abnormal in those with hypertrophic cardiomyopathy, as we said, 9 out of 10 times. So if you're using ECGs, then you have to be aware of what a normal physiologic change is with regards to, is this an athlete change? Or is this an HCM change? Knowing those differences is really critical, number one. Number two, the question is, why are we looking in the athletes? And this is still a bit controversial. You can cause harm by identifying somebody wrongly or identifying somebody with HCM that may have had no impact on their life long term. So for me, if we're going to evaluate athletes, and we do this in Major League Soccer and we do this in the NBA and the NFL, our goal is to make a diagnosis, to risk stratify them, and then come up with an exercise plan that is safe for those individuals. That way, we're not looking to disqualify them. We're looking to work with them and then hopefully integrate that into an exercise plan for them. As we know that exercise in HCM does have benefits, we have to decide what level, what the need is, and potentially what the safety level is for the individual with HCM.
So if I'm a hospitalist or something
Yep.
in the and I have to evaluate someone in the emergency department, they're mildly symptomatic, maybe a little breathless, maybe a little dyspneic. And if they don't have any real changes on the ECG, do you still suggest an echo at that point? Is it kind of stratified by age?
Yeah, so I would say that if somebody comes in symptomatic and you are suspecting a cardiac reason for their chest pain or their breathlessness, boy, it's hard not to do an echocardiogram to evaluate that individual. Once they're symptomatic, it's different. When people talk about screening, we're talking largely about asymptomatic individuals, and you're screening them blindly, often without really any knowledge of their history or family story. That's a different risk. But once you have symptoms, an ECG and an echo is really a powerful tool to investigate that. Again, based on their age, older individuals, you're going to think cardiac for sure, but their history is going to help you distinguish this. If they're a 4-pack-a-day smoker, obviously lung disease is going to be more prevalent. But even in that group, I'm still going to argue, boy, an echo is really going to be powerful to investigate that group. Symptoms that sound like it's cardiac, you got to investigate for HCM.
And can you share more about the research opportunities in HCM on the horizon?
Sure. One of the benefits of going to a large center is those research opportunities. We have about 8 different research opportunities going on right now. So just to name a few, we're looking at different cardiac myosin inhibitors to investigate both obstructive HCM as well as non-obstructive HCM. That can help defray the cost for those who are looking to begin cardiac myosin inhibitors, helps us better understand that group. And then of the non-obstructive HCMs, We have very little to offer them. So we have them in both of those. We also have them with other companies that are non-cardiac myosin inhibitors, including some unique infusions that we're utilizing to try and change the non-obstructive group. So that's what's coming down the line. It's myosin inhibitors. It's also therapies to change from glucose to fatty acid utilization in HCM, and there is some infusions with vectors that come from a plasmid that can go directly into the muscle itself, and we think will actually help at the basal cellular level. Lots of exciting things coming on the horizon for HCM.
Are there any special things that your institution is doing to help educate community cardiologists or PCPs in the identification and management of HCM right now? Any tips?
So this is definitely a wheelhouse for us. So we are educating the residents, we are educating the fellows as the next generation of those who are going to be caring for folks. And then we're delivering education to the cardiology groups. We give grand rounds. I do national and international talks to try and increase the awareness of HCM. It's really important that this becomes top of mind. It's really common. The symptoms are very common, and echo is a critical way we make a diagnosis. So we know that if you can identify some of those findings that are consistent with HCM, and echo will help you do that. Our next discussion is about AI. So this is obviously in the sweet spot of this company, and it may end up being the best way for us to have an underlying kind of watchdog or mechanism to screen all of the ECGs for typical features of HCM. We're not quite there yet, but that's part of the research we're doing. How can we better identify HCM based on ECGs that our eyes can't see, but that AI can often identify that we know in other diseases has improved outcomes and improved the diagnosis. It's an exciting time to think about how we might be using AI to evaluate those with potential for HCM.